So welcome everyone to our August ISCRR Learning Series webinar. My name's Janine McMillan. I'm one of the acting co-directors here at ISCRR, or the Institute for Safety, Compensation and Recovery Research for short. Firstly, I'd wish to acknowledge the people of the Kulin Nations on whose land many of us are based today. I pay my respects to their elders, past, present and emerging, and we extend that respect to First Nations people here today. For those of you who are new to the ISCRR Learning Series, every 2 months we present a topic on our research findings or the impact from our research and best practice management of research. You'll find out future ISCRR events by joining our mailing list through the evaluation survey that will appear when you leave this session. Our topic today is on the prevention and management of work-related violence, presented by 3 esteemed Monash University researchers. Dr Dianne Sheppard is a Senior Research Fellow at the Monash University Accident Research Centre with over 20 years research experience. Her research expertise focuses on work disability, building work capacity and returning to work for those with compensable work-related or motor vehicle accident-related conditions or injuries, addressing psychosocial barriers to achieving health and work outcomes, psychosocial hazard management, at the organisational level and exposure to work-related violence are also areas of research interest. Professor Helen De Cieri is the Director of Research in the Department of Management at the Monash Business School. Her research combines workplace management, employee mental health and organisational performance. Helen's recent research projects include studies of OHS leading indicators for vulnerable workers and workplace interventions to deal with psychosocial hazards and occupational violence and aggression. And Dr. Sarah Oxford is the Senior Research Officer in Evaluations at ISCRR. Sarah designs and delivers qualitative research and evaluation projects for ISCRR. She has extensive experience conducting research with people from socially vulnerable backgrounds, and her goal is to ensure policy and decision makers achieve a deep and empathetic understanding of the people, context and challenges that policies and programs aim to address. So I'll hand over to Dianne to start us off. Thanks, Di.
So thank you, everyone. I begin today by acknowledging the traditional custodians of the lands on which we meet today, which are many and varied, and pay my respect to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islanders peoples here and listening today. So I'm going to speak this morning about some results that are quite hot off the press and haven't yet been formally circulated. This study was recently conducted in response to the increase in psychological workers' compensation claims, and the fact that much of the research that's been conducted so far in the area of occupational violence and aggression has focused on primarily on healthcare. So there's a clear need for a better understanding of work-related violence across industry type, and particularly the financial burden associated with both physical and psychological workers' compensation claims that can be attributed to work-related violence. The Compensation Research Database offers us a unique opportunity to look at industry type and at least a large chunk of that financial burden associated with OVA. It is an administrative database established as a platform to support research into compensation health. It is held by WorkSafe Victoria and includes comprehensive data pertaining to workers' compensation claims covered by WorkSafe since the mid-1980s. So that covers over 20 years of accepted and denied population-based data for every compensable work-related injury claim in the state of Victoria. So as you can see, it's a rich and valuable resource. So the data set that we work with for this particular project spanned a 5-year period from the 1st of July in 2015 to the end of June in 2021. The way in which we identified claims, they were selected through the mechanism of injury or disease or accident type codes within the CRD, including exposure to a workplace or occupational violence, work-related harassment and or workplace bullying, as well as being assaulted by a personal person. And the claims data set was also limited to include only those that had a full 3 years of data within that 5-year time period. That is, the claims that were still open and under 3 years in duration were excluded, and closed claims were capped at 3 years of data for each individual claim from the claim start date for consistency. So what we ended up with was a claims data set that included 11,289 claims The majority were closed, around 80%. There were 18% that were still open and 2.5% reopened. So within that data set, the most represented occupations across the work-related violence claims were professionals at around 28%, intermediate clerical, sales and service workers at 24%, and associate professionals at 14%. The most commonly represented ANZIC industry groupings for the work-related violence claims across Victoria were healthcare and social assistance at around 32%, no surprises, as well as public administration and safety at around 15%, and education and training at around a similar percentage. The other two just below that were manufacturing and retail trade at around 5%. So together, the top 5 industry groups accounted for about 72% of the work-related violence claims. So what I'm going to do is briefly describe the financial burden data using one of the key payment outcome variables calculated within the CRD, which is total payment amount. So total payment amount is the total amount of all costs associated with an individual claim, which includes weekly compensation payments, incapacity payments within that 3-year follow-up period, as well as non-compensation costs, including medical expense payments, legal lump sums, etc. So note that not all of these claim costs are covered by the regulator, particularly for claims within that minor claims category. So when we did that, we ended up with a total of over 600 million of costs incurred in relation to work-related violence claims within the Victorian Workers' Compensation System over that period of 5 years, with an average amount of approximately $55,000 per claim. So I want to reiterate here that not all of this, of course, represents funds paid out by WorkSafe Victoria, but these costs are all of relevance when assessing the financial burden of occupational violence and aggression. What we did then with the data was use statistical modelling to explore overall claims costs relative to each type of work-related violence and also across industry. And so univariate modelling results indicated that the following variables were significant contributors to cost outcomes. I will just go through a few today that may be of interest due to time constraints. And so I'll begin with DEFA, which is the Index of Residential Economic Advantage, significantly contributed to the model. So whereby the top 4 deciles, so the top 4 most disadvantaged residential areas had higher claims costs. Occupational group, so what we found here was that managers and administrators and advanced clerical and service workers both incurred higher costs relative to other occupation categories. There are a few other categories in there that incurred lower costs, including elementary clerical, sales and service workers and labourers and related workers. I'm going to cover industry on the next slide in a little bit more detail, so I'll come back to that. Accident type, or the type of work-related violence, was of particular interest. So this also made a significant contribution to the model, whereby work-related harassment and bullying and a general exposure to work-related violence incurred higher costs relative to the work-related assault category. So the latter being largely associated with physical as opposed to psychological claims. And finally, the nature of affliction or injury code. So this is the V code grouping variable for those familiar with the database. This also made a significant contribution to the model. So in this instance, mental disorders, so claims associated with stress and anxiety, for instance, incurred higher costs relative to those musculoskeletal or wound-related physical injuries. So I'll leave that there. Other variables that significantly contributed to the model included age, sex, employment type, pre-injury weekly income as well. All right, so this figure here represents the percent total payment amount for each of the ANZIC industry groups for work-related violence claims. So interestingly, when we look at the frequency of work-related violence claims across industry, the graph is remarkably similar. Okay, so the largest spend that we see for work-related violence claims across industry groupings in Victoria over that 5-year period was within the healthcare and social assistance, which came in around 28% of the total spend, followed by public administration and safety at around 15%, education and training not far behind at around 13% total spend. Manufacturing at 6.6%. And then you can see there's a group of, or cluster of 3 industries: wholesale trade, resale trade, and construction at around 5%. I'll finish up with a few key messages. I think it's pretty clear that the financial burden attributable to work-related violence is significant and deserving of more targeted research to fill those knowledge gaps, particularly across those industry types that are not yet well represented within the literature. The target industries obviously include healthcare and social assistance, so there's a strong case to keep focusing on that area, but also not to ignore public administration and safety and education, as well as other sectors requiring attention. So the next steps is really taking these results and working with regulators and industry to better prevent work-related violence, and identifying those risk factors that in particular that are amenable to change. And so thank you to WorkSafe Victoria for providing access to the data as requested for this study, and stay tuned for a report and publication within the coming months. Thank you, everyone.
Thank you, Di. And I'll go straight into my presentation to follow Di. So I'll share my screen now. So in my study, to balance Di's beautiful overview of the data, which is remarkable and startling, our study sought to investigate further into the human experience of work-related violence within the healthcare sector. And we know there's a long history of work-related violence documented in the healthcare sector, and we've sought to understand that human experience and how it impacts on individuals in the healthcare sector. Our research, as Di's, is hot off the press, and so there are forthcoming reports that will soon be available based on this research. On our research, as Di's indicated, we noted that work-related violence can include physical assaults and aggression, can also include bullying and gendered violence, and we'll talk about each of those as we go through. To do our research, we surveyed healthcare workers, and around 1,400 very kindly responded to our survey. We then interviewed healthcare workers, and these surveys and interviews included nurses and midwives, but also allied health professionals, people working in mental health, people working across a range of health services from aged care through to mental health. And so we've got a broad spectrum of people working in health. We don't have medical staff working in healthcare included in this. Other research has addressed their issues. We have also interviewed, as well as healthcare workers, we asked people who are OC health and safety specialists working in health services. We asked union representatives and WorkSafe representatives about their understandings of work-related violence. Consistent with the data that Di has just presented, the people who responded to our survey said that in the last 6 months, 75% of our respondents had experienced violence at least a few times in the last 6 months. So only a small minority had not experienced any violence. The majority are experiencing violence, and they're experiencing it at least a few times, some of them experiencing it up to a daily frequency. Around half our sample, 49%, said they'd experienced bullying. That's very high when you compare it to other studies reporting on bullying. Now, to bear in mind, work-related violence is often described as the perpetrators being mainly, say, patients or clients or visitors, people external to the organisation. But we did find that some of the perpetrators, around 22% of the perpetrators of work-related violence, were people inside the organisation. So co-workers shouting, swearing, often a lot of verbal abuse being experienced by co-workers. More likely to be physical abuse being experienced, perpetrated by people external to the organisation. With workplace bullying, because by definition that involves a repeated negative experience, we found that the perpetrators of workplace bullying were more likely to be those inside the organisation, co-workers, managers, supervisors. We also asked about gendered violence, and only around 14% of our survey respondents said they'd experienced violence that they specifically identified as gendered. It was usually sexual harassment. That's what people see as gendered. But when we delved further into this, we found that what people were reporting as work-related violence was actually quite gendered in its nature. It might be a male nurse being verbally abused, related to being gay, for example. So a range of experiences were seen. And this quote draws out the human element, the experience of what it's like day to day. When we asked people about what leads to these factors, there was certainly recognition that it might be patients' clinical conditions in aged care, in psychiatric wards, in emergency departments. But our survey respondents and interviewees also pointed out that this is widespread. It's not just happening in those settings, and it's linked to systems issues where workers' health and safety is given less priority in the perspectives of the people who responded, the workers themselves. They felt that those who perpetrated violence felt they wouldn't be held accountable, there wouldn't be consequences for them. They felt that staff shortages and high workloads had exacerbated the violence and its frequency. Gendered violence was particularly discussed in terms of the devaluing of women in the workplace, the nature of care work, where women were more likely to be kind of exploited for their empathetic approach to work, and again, lack of policies. With regard to bullying, we similarly found that systemic issues such as work overloads and power imbalances in the workplace were identified as contributors. And we also asked about the well-being of healthcare workers and compared their levels of well-being to other surveys that have been done on a national level. Not surprisingly, healthcare workers reported lower levels of personal well-being, how safe they feel, how happy they feel, than the Australian adult population on average. Around 50% have moderate to high to very high levels of psychological distress, anxiety, depression symptoms, and around half have levels of burnout that are moderate, even high levels of burnout. And then when we did further analyses, and I'm not going to show you the numbers here, but when we did further analyses, workers who had experienced any type of violence had poorer well-being, higher burnout, higher psychological distress, and lower personal well-being. And when we look at the comments they gave us, it's overwhelming. Their quotes in interviews, their qualitative responses to the survey gave us example after example of both physical and psychological trauma linked to their experience of violence, and linked particularly to sexual assault, sexual harassment experience, both from patients and external people as well as their co-workers. They also pointed to what happens after an event. So a key message, work-related violence is widespread in healthcare, and the lessons we learn from healthcare could be applied across the other industries where, as Diane's shown, it's also being experienced. Because of the prevalence of violence, there's an ongoing tendency to treat it as just part of the job. People are expected to put up with it, get on, keep completing their shift, go back to the ward, keep going. But all those types of violence actually expose workers to significant harm to their physical and psychological health. And we even asked people about experiences of witnessing violence, even if it's not yourself who's the target. The impact of witnessing violence is just as bad as experiencing it yourself. The ongoing psychological trauma particularly has an impact on individuals. We found this chronic underreporting. So much happening, I don't have time to report it. I've got to get my job done. And a feeling that the response would be inadequate, that the individual would be blamed as not being able to manage their work, that nothing would happen, that they wouldn't receive the support that they sought. even if they reported it. So we see areas for potential future work around how we can move towards zero tolerance for work-related violence. We saw an amount of cynicism where workers said, look, it's what they say, but it's not the reality we experience. It's ongoing, it's happening, and we need to understand how to eliminate and how to deal with what is happening. So I do thank the support of, I'm grateful for the support of WorkSafe Victoria and ISCRR and the 3 unions who kindly allow their members to participate and encourage their members to participate, and the organisations and individuals who all participated in our research. Thank you for listening.
Thanks so much, Helen. I'll now share my screen. So we decided today to start with Di's excellent work and move on to Helen's excellent work, because I think you'll see that there's lots of themes among our projects. We looked at work-related violence, but from separate perspectives. And my research is going to look at pretty much the state of play. So WorkSafe came to ISCA and they said, you know, what is going on in terms of, they said, we know we have a problem with OVA, that's a key hazard influencing mental and physical injury claims in health services. We're interested in updating our guidelines, and we'd like to identify what interventions, risk controls, and frameworks are happening in Victorian health services to prevent OVA in Victoria. We took a mixed methods approach to this, looking at a rapid evidence review to update the literature for WorkSafe, and we also conducted interviews and focus groups with key staff from 11 health services. Now, the pandemic put extra pressure on health services, we all know this, but interestingly, OVA was reduced when visitors weren't allowed in health services, but now we're operating in this environment where staff shortages are common and OVA is increasing. And participants were asked about how OVA was managed currently in their health services. So these interviews and focus groups were conducted in late 2022 and early 2023. An interesting key finding that came out of the data collection was that in the past 5 years, CEOs have begun championing for OVA prevention and management. And the health services where this was happening was about a bit over half said that this was being really effective, particularly with the creation of OVA committees. They were saying that this benefit was that they have well-functioning OVA committees that meet regularly and include a broad range of staff voices, and that this is starting to shift the culture within these health services. The participants also talked at length about the quality of OVA training, saying that they varied by health service, and trainings were numerous that were discussed, but at minimum, they addressed the Department of Health criteria, whereas the health services that had executive leadership buy-in talked about advanced trainings that included things like risk assessments of the health service, training audits, staff surveys, evaluation, and even things that were more robust and creative pedagogically, like doing role plays, using staff stories in the trainings, as well as virtual reality. However, across the board, there were training needs that were exposed and discussed at length. And these include increasing resources for OVA teams, increasing staff and compliance. Staff shortages came up a lot, saying, you know, our staff on the floor are not meeting compliance. We can't even get them into training because we don't have enough staff. Creating prescriptive and bespoke training that can be used across services. So identifying that maybe an ED staff needs different training than pediatrics, but also that when someone moves from hospital A to hospital C, they would like to be able to take that training and not have to start over and use different resources. They also talked about needing more de-escalation training and standardized physical practical skills, and to ensure that security and non-clinical staff are also included. Now, we talked at length about interventions, frameworks, and risk controls in Victoria. More than 39 were discussed. I asked them, particularly if they had evaluated any of these, or if not, if they could provide anecdotal feedback. A lot of these are either under evaluation, or they can't share the evaluation yet, or they haven't evaluated it yet. So I basically said, well, what if you're a moving health service, what would you take with you? And these are the things that were discussed. So the first was an adverse incident reporting tool, AxiMap. So one health service explained that this has been helpful in instant investigation, but also with trend analysis and moving away from a person-centered thinking to a systems thinking approach. Incident interventions were discussed, particularly code grays and plan code grays, saying that they're extremely helpful. But in relation to this was leadership strategies. What's come out of learnings from code grays is that we really need someone who is there with experience to make quick decisions that people know they can go to. So there are different ways of doing this. One example was a clinical lead. Someone wears a particular colored jumper. Everyone knows that's the person to go to when an incident arises. Participants also talked about security personnel, such as body cameras and security observers, as well as guidelines. All health services that participated heavily lean into the ANMF 10-point plan and 10 domains of de-escalation. The frontline staff who participated in interviews talked about physical deterrence and support, saying, you know, this health service, the lights are really bright, it's loud, we have dark corners, there's things like live weight time boards that can help, or new doors that can physically make a difference. And then teamwork strategies were also discussed, such as a tap in, tap out method, where someone who's working with a complex consumer can say to their supervisor, I need someone to cover me for a bit, I need a break. So what you'll notice, I should have mentioned, a lot of those are about management, not prevention. We started this research wanting to know about prevention, but a lot of the health services said, hey, we're treading water, we're doing the best we can. We welcome more input, we're eager to participate in this research because we want to do better, but we're right now focused on management rather than prevention. So in terms of barriers and enablers, I've grouped these into 3 themes: individual, health service, and community and public policy. So on the individual level, which Helen also spoke about, there's this overall lack of staff knowledge and skills, which bleeds into staff attitudes and confidence. And I think the quote below explains that there's just overall acceptance that OVA is a normal part of the job. And this then resolves into staff underreporting because they feel like they don't have the time to report. If they do report, it goes nowhere. So there's a big barrier there on the individual level. On the flip side, enablers include a younger staff coming in or saying this is an acceptable behavior and not putting up with it. And then the staff that have felt supported from reporting and are seeing benefits from that tend to increase their confidence and to increase reporting. But that was a very small group of people that spoke of that. In terms of health services, the barriers include a lack of executive buy-in and resourcing, staff shortages, complicated data. So a lot of data is being collected, but do they have the resources to analyze it, to do benchmarking, to compare it, as well as physical structural issues that were discussed by frontline staff. Enablers include executive investment, OVA committees, and inclusion between clinical and non-clinical staff. In terms of the macro level, we have the community and public policy. The barriers here include visitor aggression, tensions between entitlements, so examples like the Mental Health Act versus the OHS Act, lack of standardized trainings and approaches to physical interventions, and confusion over the public versus the private standards and rules. Private health services are saying, hey, we would actually like to be held accountable to the same standards as the public health services. And enablers could include national standards to help with accountability, and the fact that OVA data will help combat OVA. So key findings, executive leadership championing for OVA prevention and management is shifting culture. It's starting. They're saying it's only happened within the past 5 years, but they're actually seeing change happen because of that. Most health services who participated have OVA committees that focus specifically on prevention and management. And a similar staff shortages, generic trainings, and the need for practical skills training. Because OVA is complex and health services have diverse department contexts with various needs, the strategies are many and greatly vary, and we need more robust evaluations. There are many barriers, but we need to think about them in a systematic way and look at them through the individual health service and public levels if we're going to address them. And finally, the health services were very appreciative of WorkSafe's efforts to date and that they were asked to be a part of this research. They were eager to participate in the research. So thank you very much. I'll now pass it back to Janine.
Excellent. Thanks so much, Dianne, Helen, and Sarah. There's been a lot of discussion in the chat and the Q&A about, whether these results are surprising or not. We might just touch briefly with each of our speakers and, what things in your research did you find that was surprising? We'll start off with Di.
Thank you. Yeah, I guess the overall figure struck me as surprising to a certain extent. The 6 million over the 5 years, and that really is a gross underestimation of the financial burden. If we think about, this was covered by both Helen and Blair, there's gross underreporting of OVA. So we've missed a lot of cases. These are only the cases that that have been reported and then have resulted in an accepted claim. And so, you know, these data are really valuable and really useful, but it is a gross underestimation.
One of the things that was sadly surprising was the 50% of survey respondents indicating that they'd experienced bullying. When we did a similar survey in 2014, 2015, it was a lower level. So it seems as though the stresses on the system in the last couple of years have caused stresses for people in their interactions with others. And so we're seeing more tensions in the interactions that workers are having in healthcare. The other thing that was really surprising for me was that only 14% of people responding to the survey identified gendered violence. And maybe it's my lens. I could see a lot of gendered violence in the violence that was reported, but it seemed like it's not recognised or not well understood as gendered violence. So when we asked them, well, how do you describe the violence you've experienced? They described things that were very gendered. There was everything from sexual assault, sexual harassment, through to really nasty name calling that was very gendered, and treatment that linked to their gender or their identity. And so they were the two really surprising things for me.
Thanks, Sarah.
I think from the get-go, I was really surprised at how eager the health services were to participate in the research and how happy they were that WorkSafe want to be more involved with this issue. They really welcomed it, and that surprised me. But also, as far as the data, it was the CEO investment and how much of a difference that's making, and how that's really changing the internal culture. It's slow, it's going to take time, but having people say, yes, we want you to do this training, yes, we want this committee, yes, we want to see the data ourselves and learn from it. I think that's hopefully a shifting point towards a positive direction that I didn't expect to see.
Excellent. Thanks, Sarah. Di, this one's for you. This is coming from our audience as well. Are payout amounts per claim different between different sectors? So really, you know, the dollars per claim, do you find differences between different sectors?
That is an excellent question, and it's something that I didn't report today, but yes, they are, and we'll, in the full report, we'll describe those data, but off the top of my head, I'm sorry, I can't pull out those differences. So yeah, excellent question. You'll see that in the report that's coming out.
Excellent, thanks, Di. Another one is a question for Sarah. Hi, Sarah. Did the Mental Health Royal Commission get discussed?
It did not come up.
No?
I don't remember that coming up specifically.
Another question we've got. Do you think the recent changes in legislation surrounding the management of psychosocial risks and hazards will have a positive impact on the management of OVA? We might start with Helen for this one, but anyone else can add anything?
I would hope so, but we need to provide this evidence and then look at the resourcing of the management of psychosocial hazards. One of the issues that was raised was that managers may not have, or supervisors may not have the skills and training themselves to understand how they could respond when an experience of work-related violence is reported. And so their responses are really important. Where people did report an incident and they got support, that made a huge difference to them. The response of their supervisor and feeling that they were supported made a huge positive impact. Where they did not feel supported, it had a compounding effect. And in some cases, they said it was actually worse than the original incident because I felt that I wasn't supported by my organisation. So I would hope that this raises awareness of the importance of training, resourcing and supporting people. We know the system is stretched. We know that workloads are high. We know that they're dealing with a range of issues. And that is all, unfortunately, contributing to what we're seeing and requires attention.
Excellent. Thanks, Helen. Does anyone else, Sarah or Diane, want to add to that?
I think to build on it, we have to consider how it's a behavior change problem, both from society and how they're treating staff, but also in how staff are accepting this violence as normal. And so, we want to see both of those things change. And I think the impact will depend on how it's implemented and enforced. And we don't know what that's going to look like really yet. And it could vary by health service as well, despite trying to be standard. So lots of question marks around it for me.
Yeah, I don't really have anything to add. I think that the legislation changes may help to increase awareness, and it may improve reporting, encourage reporting. But I agree. I think that some really sound and kind of best practice guidelines around how to manage will be really important, and even to the point where we may need to think about some industry specific advice about and guidelines about management. So it's a space to watch, definitely.
Excellent. I think this may be for Di, this question, but anyone else is welcome to answer. What's the trend of the numbers of complaints year by year? And is that the same across all industries? Do we actually have that data, Di?
I haven't actually looked at that. I guess it is of interest, coming out of COVID, we did see some changes. So yeah, sorry, I can't answer that question right now, but it is something that I'll make note of and try to look at within the data set. So thank you.
Excellent. Excellent. A question for Helen in the chat. Was there any discussion relating to the spectrum of support systems and the communication between, say, NDIS coordinators in the hospital? Any discussion on that?
It did come up. We did have some disability support workers who participated in our research. And to be honest, they raised a range of issues that were kind of beyond the scope of what our study was about. I think there is real potential for future research that could explore issues specific to disability workers and NDIS issues. So it did come up among the range of issues that were in our study. And yes, thank you, Nella, for raising your perspective and your personal experience. It's often really complex. Each incident is complex in itself, and there's a whole range of issues and a range of people who are involved, and understanding the training they may have, the support they may have, whether they're a security worker, whether they're a nurse, whether they're a disability support worker, they're each working within quite different frameworks and levels of experience and understanding. And so supporting them requires, I would say, more attention. Thank you.
Excellent. And I think looking at the time, this might need to be our last question. What broader data or information on management exists for consideration? This can be for anyone. So what broader data or information on management exists for consideration internationally? Are there similar countries or cultures managing these hazards better? Does anyone want to have a go at that one?
I'd say it's certainly an international issue. There are researchers in all other countries I can think of who are looking at this, and there are healthcare workers and other industries who are looking at this. I think Di's research is really important because it's showing that it's not just in healthcare where it's happening. And our research shows that it's not just in the parts of healthcare where people usually think. It's a broader, and as Sarah said, a societal issue to deal with violence and how people are treated and how we interact when we're all under stress. And it covers a whole spectrum of issues, from rolling your eyes at a retail worker and being impatient through to criminal activity. So I think there are countries around the world dealing with it. We see examples of systems that are doing really interesting things, but there's still a lot of progress and a lot of discussion about progress to be made.
Excellent. Thank you so much, Helen, Sarah and Diane. And thank you to everyone for attending today. And I apologise again for the delay in the start. But there will be an evaluation pop up after when you leave this session, and you can ask more questions in that as well if you'd like to. Okay, thanks so much.